So we'll be talking about nasopharyngeal carcinoma. Okay. So what we need to actually remember is nasopharyngeal carcinoma malignancies. Okay, like 85% of the adult nasopharyngeal malignancies are carcinoma. Okay, and the most important here today we'll be learning is nasopharyngeal cancer. Now it's more common to Chinese and North African people. You need to understand that whenever we talk about nasopharyngeal cancer, Chinese population use of nitrosamines, okay, seafood, these are the different, indications that we are talking about nasopharyngeal cancer, okay. And remember that most common it is squamous cell carcinoma. And if you look grossly, it looks proliferative, ulcerative, and infiltrative. Usually seen in the old age, but can also be seen in the young age. Okay, so what is the presentation of the patient? How will the patient present with? The patient presents with a mass at the nasopharynx. If there is a mass at the nasopharynx, of course it will lead to impaired ventilation of the eustachian tube. That will lead to OME, right? Similarly, a person has a mass at the nasopharynx. The sinuses are not well ventilated. That will lead to features of sinusitis. Okay? There's this mass can actually go towards your sinus of Morgagni above. It can go downwards, it can go frontwards, it can go backwards. If it go frontwards, it will come towards the nasal cavity, and if it comes towards the nasal cavity, there will be all the signs and symptoms of a nasal blockage. Okay, so if it goes upwards, so it's involving the cranial cavity, having a bad prognosis. It can go towards the orbit also. Okay, so towards backward, it is actually involving your vertebral area. Okay, and downwards it is involving your oropharyngeal, and again towards your hypopharynx. So this was all about the etiology. See, HLA-A2 and HLA-B sign 2 are the important risk factors for nasopharyngeal cancer, and the important one being the Epstein-Barr virus. Remember, or HPV virus. HPV virus is associated with human papillomavirus is associated with juvenile papillomatosis, as well as it is associated with the other most important, which is sinonasal tumor. Okay, so exposure to nitrosamines, as I already told you, smoking, infection, poor ventilation to the nasopharynx. Now WHO has classified nasopharyngeal tumor into 3 types. One is keratinizing, one is non-keratinizing, other one is undifferentiated. So this is actually a generalized classification: keratinizing, non-keratinizing, and undifferentiated. Keratinizing, non-keratinizing, and undifferentiated. So before understanding, now we need to understand about the anatomy of the pharynx. So you can see here, this is the nasopharynx. This area is your skull base, which I have marked with red. Okay, this area is your area extending your soft palate. So if like this, there's actually the elevation of the soft palate that I've shown you here with a green pen, and when there's an elevation of the soft palate, the food doesn't regurgitate over here, isn't it? So next thing that we need to remember whenever we talk about nasopharynx is this area can go over here, can go over here, can go over here, can go over here, can over here. Okay, so this is actually the presentation. It can also go towards your orbit. Okay, above. Next. So see, this is your fossa of Rosenmuller. So this is your opening of the eustachian tube, and insiding there is a depression. It's more clear in the next slide. See here, this area. Okay, area number 3. Okay, of depression area. Okay, this is your opening of the eustachian tube. Next, see here, this is the muscles of the pharynx. This is the muscles of the pharynx. If you can appreciate, salpingopharyngeus, palatopharyngeus, stylopharyngeus, these 3 are actually SPS. These are the longitudinal muscles. Superior constrictor, middle constrictor, and inferior muscle constrictor are the circular muscles. They come together and join towards the midline raphe. So this is the midline raphe. Okay, which I am marked with purple. This is the midline raphe. So these 3 constrictor muscles, they come and join towards the midline raphe. The constrictor muscle, when it comes and joins over here, there's a potential space in between this above superior constrictor muscle and the base of skull. This potential space is known as sinus of Morgagni. This sinus of Morgagni, it consists of certain important structures, that is can be remembered by the mnemonics thala, ascending pharyngeal artery, tensor veli palatini, levator veli palatini, auditory tube, and ascending pharyngeal artery. Okay, so these are the different components that is present in sinus of Moriarty. Any tumor from the nasopharynx, if it goes and involves this thala structure, okay, it can actually create a troublesome problem. You can see here, above here you have the eustachian tube, the base of the skull. Somewhere here below the base of the skulls you have your nasopharynx. So it can actually involve your eustachian tube. Masses over here, it can involve the eustachian tube. That is why the patient presents with conductive hearing loss. Unilateral otitis media with effusion in a Chinese population. Now if you can see in this diagram, you can see foramen lacerum and you can see the jugular foramen and carotid canal. This is the area of the nasopharynx. So if in case it goes to these structures, patient may present with Horner's. Patient may present with 9, 10, 11, 12 cranial nerve palsy. So presentation can be anything ranging from a mass in the nasopharynx to severe symptoms. Now if you need to say the first symptom that the patient presents with is a neck swelling. Posterior neck swelling, that is known as Rouvier sign. Remember, Rouvier lymph node, we studied this Rouvier's lymph node in the retropharyngeal space. But that was a Rouvier's lymph node. This is a Rouvier sign. Okay. Bilateral enlarged upper and middle deep cervical nodes with posterior triangular nodes involvement. Nasal area with epistaxis nose blocked nasal discharge. As I told you, it can come above, in front into the nasal cavity. Otologic signs and symptoms, they can be conductive hearing loss and deafness. Ophthalmologic symptoms, as I already told you, if it directly involves the ophthalmic area, ophthalmologic symptoms, or if it involves the cranial nerve 3, 4, 6. Similarly, they can be diplopia, ophthalmoplegia, proptosis. So one differential diagnosis for proptosis is also nasopharyngeal cancer extending into your eyes. Okay, now neurologic, I told you that there are two foramens, jugular foramen as well as your carotid canal is there, jugular foramen is there, and foramen lacerum is there, right? So whenever we talk about jugular foramen syndrome, there's the involvement of 9, 10, 11 involves, okay, along with the Horner's syndrome. I already stated here also. So patient may present with Horner's syndrome. Next is Totus triad. If you are sleeping, please wake up. Totus triad is very, very important, often asked in your examination. So ipsilateral, you can remember by the mnemonics NPC. P is palate, C is conductive hearing loss, N is neuralgia. Ipsilateral temporoparietal neuralgia. Temporoparietal neuralgia, very, very important word. Okay, trigeminal damage. So ipsilateral, you can remember ipsilateral neuralgia, temporoparietal neuralgia, ipsilateral palatal paralysis because of the damage of the vagus nerve, and of course there will be conductive deafness because of the involvement of the eustachian tube. It can metastasize distance to the bone, liver, lung. Okay, for this we need to go for a PET scan. You can go for a PET scan. Now if you look here, you can see a mass in your posterior triangle of the neck. This is known as Rouvier's sign. Rouvier's sign. So any lateral neck swelling, if is asked in your examination, lateral neck swelling, you just write laryngomalacia. You write laryngocele, not laryngomalacia. Okay, laryngomalacia is a congenital anomaly. You write laryngocele. You write carotid body tumor. You write involvement of the nodes by the infections like tonsillar infections, etc., etc. And then you write about branchial cleft. Also, you can write about nasopharyngeal cancer. Okay, you can see here there's ptosis, and there is adduction palsy. Adduction palsy means basically it is adduction is brought about by medial vectors, abduction is brought about by lateral vectors. Left proptosis. Okay, now you can actually evaluate. This diagram is present in Dengra. Okay, cranial nerve palsy can be seen, pterygoid muscles can be seen, neck stiffness and pain, retropharyngeal nodes are involved, right? Just understand. Next, you can go for a blind biopsy if in case you are not seeing any mass. If you see a mass, it's good enough. You can go for posterior rhinoscopy examination. You can go for direct nasopharyngeal examination, nasopharyngoscopy, nasal endoscopy. Tumor mass is seen in the nasopharynx. Common site is the fossa flossimolar. Nasopharyngeal tumor biopsy can be seen or blind biopsy. FNSC can be taken from the involved node, okay, and CT scan head and neck. You can also go for a PET scan if in case a whole body is, mets are present at a higher area. You can go for a PET scan, okay. MRI head and neck to rule out intracranial extension. Serological marker, because it's an Epstein-Barr virus infection, so you have to go for a serological test. Do not miss this. Immunofluorescence test, okay. Next, so there are basically two important terms whenever it comes to nasopharyngeal cancer, okay. One is okay, so okay, we'll talk about that later. So nasopharyngeal screening is CT scan. Now let's talk about the TNM classification. T1 involved with the mucosa, just mucosa. T2, remember, just make this 2 ulta, S, soft tissue involvement of the oropharynx. T3, remember PNS involvement, 3 word, PNS. T4, other all sites, orbit, infratemporal fossa, cranial nerves, all are T4 type of TNM classification. Similarly, N0, N1, N2. N0, N1, N2. So N1 is unilateral, N2 is bilateral. N0 means no evidence of regional lymph nodes. M0 means no mets, M1 means you have distant mets. Now this is the HO triangles, Rose triangle or supraclavicle triangle. Stage 1, 2, 3, 4. T1, T2, T3, T4. N0, N1, N2, N3. M0, 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 N1. Differential diagnosis. Treatment, you can go for either brachytherapy. Brachytherapy is of 3 types: interstitial, intralesional, and one is high dose. You can go for chemotherapy, surgery. Surgery, you can go for nasopharyngectomy. You can go for radical neck dissection, but the major one being the radiotherapy. The first therapy is radiotherapy, similar to that of your laryngeal cancer. External beam radiation gives radiation all over, radiation all over. When radiation all over given, surrounding structures are also involved. Brachytherapy, one is interstitial, other one is intracavitary, other one is high dose. Interstitial means you give a radioactive substance, that is radium, iridium, iodine, gold. It is inserted into the tumor tissue, that is interstitial. Intracavitary means radioactive substance is placed inside the catheter. You can remember by this one. See, this C is a catheter. It's a probe, right? So intracavitary, you need to keep it inside a catheter and then you can keep it inside the nasopharynx. High dose, highly intensity is delivered to the tumor site. Very, very good modality. So interstitial, just keep the radioactive substance into the tumor. Radioactive substance, radium, iridium, iodine, inserted into the tumor. Intracavitary, inside the catheter. You keep it inside the catheter and then you insert it into the nasopharynx. High dose brachytherapy. Now chemotherapy, cisplatin, fluorouracil. Next, surgery, nasopharyngectomy, cryosurgery, radical neck dissection, maringotomy and grommet insertion, and bulking, palliative debulking for T4 tumor. Okay, so this was all about your nasopharyngeal tumor, and this is the summary of prognosis. Thank you, everyone.